Thank you, and good morning. I'm very happy to be presenting at this meeting on the ethical considerations in developing evidence base for pre-exposure prophylaxis in pregnant women on behalf of myself and my co-authors, Maggie Little and Annie Lyerly, who is the principal investigator for the PHASES project based at UNC. So as we are all aware, there is an urgent and tremendous need for effective HIV prevention and treatment during pregnancy. There are approximately 18 million women who are HIV infected globally, and millions more are at risk of becoming HIV infected, most often through unprotected intercourse. Approximately 1 million women of reproductive age become infected with HIV every year. And as we know very well, unprotected sex may also lead to pregnancy. So it creates this circle of risk where many women with HIV become pregnant, and also pregnancy appears to increase the risk of acquiring HIV. We also know that acute HIV infection in pregnancy is associated with high rates of vertical transmission. Every year, about 1.5 million women living with HIV give birth. PMTCT has been the primary focus of the bulk of the research around HIV and pregnancy. And in fact, HIV/AIDS is one of the few areas of research with a long track record of involving pregnant women, with large clinical trials to ascertain the most effective regimens of antiretroviral medications to prevent vertical transmission of the virus during pregnancy, labor and delivery, and breastfeeding. And while not uncontroversial at their beginning, these efforts, of course, have been hugely successful. However, there's been comparatively limited research on treatment and prevention of HIV and comorbidities focused on maternal health outcomes in pregnant women. In order to encourage and facilitate the responsible inclusion of pregnant women in HIV research, the PHASES study, which is our acronym for Pregnancy and HIV/AIDS Seeking Equitable Study, is seeking to develop consensus-driven guidance on how to ethically include pregnant women in this work. So the aims of our 4-year NIAID-funded study are to identify scientific priorities in perceived barriers to and novel research designs for HIV research and pregnancy, and to characterize reasoning around study participation or not from the viewpoints of affected pregnant women, to conduct scholarly, ethical, and legal analysis of conditions for responsible HIV research with pregnant women, and we actually have our PHASES legal team with Professor Anna Mastriani and Dr. Leslie Meltzer-Henry. And ultimately, to develop and disseminate to the HIV research and IRB rec communities a concrete engagement-driven guidance document delineating when and under what circumstances pregnant women can and should be included in HIV research. So the proposed case that we're going to discuss in a moment around PrEP highlights issues for consideration that are often at play when seeking to develop an approach to responsible research with pregnant women. So we're seeking to flag some of these issues here and generate discussion, and I very much look forward to hearing your thoughts on the issues raised. As part of the work that the PHASES team has been involved in to develop a better understanding of the complex reasons for this exclusion of pregnant women from much of HIV research agenda, we've engaged with stakeholders working in the US and in Southern Africa. We've talked to over 70 at this point, including investigators and clinicians, So these experts have echoed and expressed a real pressing need for more evidence to effectively meet the health needs of pregnant women, including safety, efficacy, and appropriate dosing of newer antiretrovirals for pregnant women, research on emerging preventive strategies, and treatment of co-infections. And unsurprisingly to those who are here today, they also described a widespread reticence to include pregnant women in HIV biomedical research, citing multiple reasons, including, of course, ethical and legal complications, challenges in weighing potential benefits and risks for women and the fetus. One investigator referred to this as this catch-22. A lack of safety data sparks concerns about unknown risks of exposure, leading to reluctance to include pregnant women in research, further perpetuating this lack of data. Also cited were challenges interpreting regulations, specifically, as we've talked about here, U.S. regulation, subpart B, and a generalized presumption that pregnant women, a generalized erroneous presumption that pregnant women are ineligible to participate under current regulations, and combined with a resulting reluctance to even approach research ethics committees with these proposals. Additionally, extremely cautious interpretations of minimal risk was also cited as a factor thwarting this research, as well as concerns about the burdens of research participation on pregnant women themselves. Certainly fears about individual and institutional legal liability if the offspring were harmed were disincentives for some researchers. Investigators also described the logistical challenges of that can accompany research with pregnant women, including collecting data at fixed time points and getting buy-in from men to recruit pregnant women in some communities. There's also reputational risks to the investigators if this study results in fetal harm, and a belief that funders, regulators, and the public would only view observational studies as ethical. And also discussed was that it's easier to obtain funding and conduct research with other populations. So ultimately, these roadblocks have resulted in evidence gaps about safety and toxicity and efficacy, reticence to use beneficial medications, and the denial of access to direct benefits of research participation have resulted. So PrEP, pre-exposure prophylaxis, the prevention of HIV through a daily pill. It has not been studied prospectively in pregnant populations. In fact, pregnancy has been an exclusion criteria from all major trials of PrEP in Africa, and women who have become pregnant on such trials are required to, have been required to discontinue the medication. However, what do we know about PrEP in pregnancy? There's certainly some things that we don't know, but we do know that evidence suggests that it is very safe. There has been no significant associations between PrEP and adverse pregnancy outcomes, and this evidence has come from 3 types of studies. Studies of women living with HIV receiving combination antiretroviral treatment. Also studies of TDF used by pregnant women for prevention of maternal to child transmission of hepatitis B. And in fact, the adverse events rates were lower among hepatitis B mono-infected women as compared to HIV-infected women in these studies. And also among women with incident pregnancy during PrEP trials show no evidence of adverse pregnancy outcomes. However, the exposure to PrEP is limited generally to the first trimester in those trials when they're removed from the study medications. And certainly we have to consider that the risk-benefit ratio of using these compounds is different for prevention as opposed to treatment, which complicates these studies. One of the results of this lack of data have been conflicting guidelines, which have caused a lot of confusion. So the World Health Organization is permissive of PrEP in pregnancy. PrEP is recommended as an additional prevention choice for people at substantial risk of HIV infection, where substantial risk is defined as more than 3 per 100 person years in the more than 3 infections in the absence of PrEP. 2014 meta-analysis by Drake and colleagues found the pooled HIV incidence among pregnant women in HIV in sub-Saharan Africa was 4.7. So they certainly meet this requirement of substantial risk. The WHO does say that further research is needed to fully evaluate PrEP use during pregnancy and breastfeeding. However, the South African guidelines state that PrEP in pregnant or breastfeeding women is contraindicated, while noting that the risk of seroconversion during pregnancy is high, and the risks and benefits of PrEP should be discussed with potential PrEP users, allowing the women at high risk to make an informed decision regarding use. So the proposed case we have for today is a prospective study of oral PrEP for pregnant women at risk for HIV. This is adapted from a study being developed by the IMPACT Network. It's the IMPACT 2009 study, an observational cohort study comparing pregnancy outcomes between women at risk for HIV taking oral PrEP and women at risk for HIV who decline PrEP during the antenatal period. And this would be the first large prospective study of PrEP in pregnant women. The sites for this study and development include 4 countries in Africa: Malawi, South Africa, Uganda, and Zimbabwe. HIV-negative pregnant women would be offered PrEP at their first antenatal visit. The target sample size is 300 women, with 200 women receiving PrEP and 100 women refusing PrEP. There would be monthly clinic visits during pregnancy and for 6 months following, with the outcomes, the primary outcomes being pregnancy outcomes, so including preterm delivery, miscarriage, stillbirth, as well as PrEP adherence over time, measured by plasma drug concentrations. And of course, also monitoring the women's liver function and HIV status, among other things. For the infant, looking at the health and development for the first 6 months of life, particularly congenital abnormalities, weight, length, head circumference, liver function, serum chemistries. So this proposed case presents issues for consideration, as we said before, that are often at play in determining and seeking to develop an approach to responsible research with pregnant women. While the purpose of PrEP is to prevent maternal disease, success in that endeavor would also carry potential benefit to the fetus, particularly when acute infection occurs during pregnancy and there's such high rates of vertical transmission. So the potential benefits to the fetus including not being exposed to and potentially infected with HIV, and then also not being gestated in the compromised environment of a woman infected with HIV. That said, the prospect of direct benefit for the woman is greater than for the fetus in a PrEP trial. Although the risk of vertical transmission is high, it occurs in a subset of maternal infections. Okay. As Maureen mentioned, it is important to consider similarities and differences between PrEP and prevention of maternal to child transmission trials. The first question I would pose to the group is if there are ethically relevant differences between the risks of interventions in the context of prevention of fetal disease, as in PMTCT, which is widely seen as acceptable, versus the context of prevention of maternal disease, which is the case with PrEP. The case also begs us to consider whether and how much an increment of prospect of maternal benefit can justify potential risk to the fetus. So, one approach taken in trials, of course, is is to generate data-driven risk-benefit ratios for the fetus exclusively, and then ask whether any leftover fetal risk, unjustified by the potential for fetal benefit, could be justified by the maternal benefit. However, a challenge in this scenario is, of course, the unknown risk of HIV to the pregnant woman taking PrEP. So how do we responsibly navigate this unknown? We would certainly argue that some increment of risk definitely could be justified, and the regulations would allow. As Maggie said yesterday, we don't ask pregnant women to forfeit all access to medical benefit just because they're willing to carry a pregnancy to term. And then lastly, when in the development of new interventions should pregnant women be included in trials? Given the urgent need for preventives used during pregnancy, the study raises the question about whether pregnant women should be included earlier and in studies designed to assess efficacy. Some might say that this was too late inclusion, but this is certainly not a one-size-fits-all question, dependent upon the study compound, including any existing safety data, and the compound's biological plausibility of fetal risk. However, in order to facilitate movement towards a biomedical research culture that is more inclusive of pregnant women and their health needs, we need to map out the considerations in making the appropriate staging determinations, and very much welcome your perspectives on this issue. So in summary, and I believe I'm just about out of time, there is an urgent need for HIV preventions during pregnancy. A prospective trial of PrEP among pregnant women would be an important step to achieve this. We discussed some of the key ethical issues, although there are many more to consider. We do hope that through this discussion that we will have in the Q&A period, and then also in the small groups, that it will help further inform the development of our ethically responsible action guiding recommendations for addressing gaps through research in pregnancy. Thank you very much.
The format that we've been following and take specific questions for Dr. Sullivan. Any points of clarification, questions about the details of her case study? Do we have mics to go around, or should I?
Thanks for the presentation. I was wondering about a scientific concern of using the control group as those that refuses to use the drug, because maybe they have a different profile risk.
Absolutely. I think it's certainly not the gold standard design, and there are downsides to this approach. We would certainly want to ensure that the best assessment of risk that we could do through written instruments and surveys is done, but again, it's an imperfect comparison. I agree.
Hi, my name is Ignacio Mastroleo from Flaxo, Buenos Aires. Thank you, Kristen, for the excellent presentation. I have two questions of clarification. If I understood correctly, the intervention is Truvada or chemotherapy?
Truvada, yes.
Yes, okay. And is there any provision in place for post-trial access of the women that are taking Truvada in case it turn out to be, because they might not be pregnant, but they may still be on risk of while?
I think that's an excellent point, and one that we would want to ensure was in place. For this trial that's currently in development, some of you may know better than I do, as I imagine you may have been involved in some of these ethical discussions. I would certainly hope that that is in place. I don't know for sure, but I think it's an excellent point.
Okay, thank you very much.
My name is Mary Kasule from Botswana. Mine is just, a point of encouragement to share the success story of Botswana. Because research was being done among pregnant women, the vertical transmission now has been reduced to 2.2%. Initially, 38.1% of the women who came to attend antenatal clinic were HIV positive. And because of the urgent need in the country, the guidelines do not permit pregnant women to be involved in research, but this had to be, changed or accommodated to carry out this research. Mm-hmm. And really, the success has been wonderful. You hardly get any children now born HIV positive. So what I'm saying is that it's possible if we can be flexible, right from the policymakers, IRBs, researchers, and so on. Thank you.
Great, thank you. I thank you, Mary, for the comment. I very much appreciate it and appreciate the words of encouragement. I would like to go back to the first question for a moment and just clarify that this is not an effectiveness trial. This is really looking at pregnancy outcomes as well as adherence. And so while they certainly may not be matched on risk and or other relevant potential confounders in these other outcomes, it's perhaps a design that makes sense for what the outcomes of primary interest are here.
Any other questions of detail or specific questions about the case study? I think there's one more in the back.
Also for adherence in the preparing period, because it's quite common that the babies take a lot of time of the mothers, and some of them skip their own care in order to take care of the baby, and we have some experience on that in Brazil.
Absolutely. I think that's an excellent point, Ricardo. Thank you for that. Certainly adherence in the postpartum period is a real challenge, and that would need to be continually monitored.